Welcome to Evidence Mastery with Dr. Masood Tusi. I am going to help you understand what Huntington disease is and how it is managed. Please note that this video is for education only and will not replace your doctor's advice. So, today we're tackling Huntington's disease. It's a really complex, inherited neurodegenerative disorder, and it has a profound impact on not just the patients, but their entire families. Our goal in this explainer is to systematically break down the current medical evidence, all to give you a clear, really comprehensive understanding. Okay, so here's our game plan. We'll start by defining the disease and then dive into what's actually going on at a biological level. After that, we'll look at the signs and symptoms, how the disease progresses, and how it's diagnosed. And we'll wrap up by talking about the current approaches to treatment and supportive care. Let's get started. All right, first up, defining Huntington disease. Let's really establish a clear foundational understanding of what this is. So at its very core, Huntington's is what we call an autosomal dominant genetic disorder. Now, what does that mean? Well, it means that if a parent has the gene, their child has a 50-50 chance of inheriting it. Clinically, we define it by a classic triad of symptoms. You've got a movement disorder called chorea, think involuntary jerky movements. Then you have a whole range of neuropsychiatric symptoms, and finally, a progressive decline in cognitive function. Now, you might be wondering how common this is. While it's actually the most common cause of hereditary chorea, Huntington's is still a relatively rare disease. The evidence, and this comes from a big meta-analysis in 2022, tells us the worldwide prevalence is about 4 in every 100,000 people. And it's really important to know that it affects both men and women equally. Okay, so we have the clinical definition, but what's the underlying cause? I mean, how can a single genetic hiccup lead to such widespread and, well, devastating effects on the brain? To understand that, we have to look at the pathophysiology. So the problem really starts deep inside the brain. Specifically, a part called the caudate nucleus begins to atrophy, which just means it shrinks. At the same time, we see the degeneration of these special inhibitory neurons in a key motor control area called the corpus striatum. Now, when you lose those neurons, you lose the key neurotransmitters they produce, especially one called GABA. You can think of GABA as the brain's brake pedal for movement. So when you lose that brake, well, that's what unleashes those involuntary movements of chorea. And you know what? All of that complex brain pathology can be traced back to one single source, a mutation in a gene called the Huntington gene, or HTT, which sits on chromosome 4. The mutation itself is really specific. Inside the HTT gene, there's a repeating DNA sequence, CAG. In a normal gene, the sequence repeats a certain number of times, no problem. But in the mutated gene, this CAG sequence just repeats over and over and over again, way too many times. You can think of it like a genetic stutter. And this stutter causes the cell to produce a toxic, misshapen version of the Huntington protein. This bad protein then builds up inside neurons and just wreaks havoc on their function. And this leads to a really direct and honestly predictable relationship. The more of those CAG repeats a person has, the earlier the disease tends to start, and the more severe it's likely to be. It's a direct correlation. This can also lead to a phenomenon in families called anticipation, where we see the disease appearing earlier and with more severity in each new generation. Okay, so we've talked about the genetics and the brain changes. Now let's connect that to the real world. How does all this underlying pathology actually translate into the clinical signs and symptoms that patients and their families experience every day? The onset of Huntington's is usually pretty insidious, meaning it creeps up slowly. The first symptoms often start appearing somewhere between the ages of 35 and 40. And from that point on, it's a progressive disease. The evidence suggests that the average time from when symptoms first appear to death is about 13 to 15 years. So the symptoms really show up across that clinical triad we talked about earlier. First, the movement disorder. This is most famously chorea, but it can also include slower, writhing movements and even things that look like tics. Then there's the cognitive decline, which unfortunately progresses to dementia. And finally, the psychiatric disturbances can be really profound. We're talking depression, apathy, irritability. And what's crucial to understand is that the evidence shows these cognitive and psychiatric issues can often show up before the more obvious movement problems begin. Yeah, the motor symptoms are often what people recognize most about the disease. Patients can develop this really characteristic unsteady gait. It's sometimes described as being puppet-like. You might also see involuntary facial grimacing. And there's this other interesting sign called motor impersistence. What is that? It's an inability to sustain a simple, voluntary action, like trying to keep your tongue stuck out for a few seconds. So, given this really complex mix of symptoms, how do clinicians actually piece it all together to arrive at a definitive diagnosis? Let's walk through the diagnostic process.
The process really starts with a deep dive into a patient's clinical picture, right? A thorough evaluation, looking for those characteristic symptoms, and, this is a huge clue, a positive family history. But the definitive confirmation comes from genetic testing. That test directly counts the number of those CAG repeats in the HTT gene. And while that's the final word, neuroimaging can also be really helpful to provide supportive, visual evidence of the changes happening in the brain.
And this is a great example of what that looks like. Neuroimaging, like an MRI scan, can show us the structural changes. So if you look here, we can compare a healthy brain on the left with the brain of a patient with Huntington's on the right. See that difference? You can actually see the atrophy or the shrinkage of the caudate nucleus. That is a hallmark finding in this disease. All right, we've now arrived at our final and maybe the most critical section. How do we manage Huntington's disease? What does the current evidence tell us about effective treatment and supportive care for patients? This is probably the most important thing to understand right up front. Right now, there is no cure for Huntington's disease. There's also no treatment that can slow or alter its progression. So because of that, all of our current medical management is what we call supportive and symptomatic. The goal isn't to stop the underlying neurodegeneration, but to manage the specific symptoms to improve a person's quality of life as much as possible. So when it comes to managing the chorea, those involuntary movements, international guidelines from 2019 point to a few options. VMAT2 inhibitors, like tetrabenazine, are used quite often. Basically, they work by depleting dopamine in the brain, which helps dial down the unwanted movements. Certain antipsychotics can also help suppress chorea. But, and this is a big but, it's always a careful balancing act. These medications can have pretty significant side effects themselves, like making depression worse or even causing Parkinson's-like symptoms. But effective care is so much more than just a prescription for chorea. The real standard of care is a multidisciplinary team approach. This means bringing in specialists from all over. It includes using medications like SSRIs for psychiatric symptoms like depression. It means physical therapy to help with mobility and balance. And as the disease progresses, speech and swallowing therapy become absolutely critical. On top of all that, nutritional support is a key piece of the puzzle to maintain a patient's overall health. Now, given that Huntington's is hereditary and the implications are so profound, genetic counseling is an absolutely critical part of care. I really can't overstate this. It's especially true for at-risk first-degree relatives. We're talking about the children and siblings of someone with the disease, particularly if they're thinking about starting their own families. Professional counseling is a must before anyone ever undergoes predictive genetic testing. And finally, because this disease is progressive and incurable, it is so important for patients and their families to start talking about advanced care planning and end-of-life care early on. I know these are incredibly difficult conversations to have, but they are so necessary. Having them ensures that a patient's wishes can be known and, most importantly, respected as the disease runs its course. So let's end with a final thought about the future. We've known the precise genetic cause of Huntington's for decades now. We know the exact gene, the exact mutation. The fundamental challenge, the mountain we have to climb as a medical and scientific community, is this. How do we translate that incredible genetic knowledge into a therapy that can actually modify the disease? A therapy that can finally slow, or maybe even stop, this devastating progression. I hope you enjoyed this video. Please feel free to share your experience or questions in the comments. Please note that I won't answer personal questions. If you found this video helpful, don't forget to subscribe to my channel.